as a pressure load to the left ventricle. What are your thoughts? I'm hearing Charlie. Yep, that's correct. So kind of the key thing is, so you're looking for a pressure thing, not a volume thing. So volume is a regurgitation kind of thing. So that kind of eliminates regurgitation options, right? So that leaves your stenosis. But this is a left ventricle problem, or high pressure in the left ventricle. The mitral valve, the mitral stenosis, does not cause an elevated pressure in the left ventricle. It only causes it in the left atria, okay? So that's where the distinction is between mitral stenosis and aortic stenosis, and why aortic stenosis is the correct answer is because you're looking at which one of these causes a specific problem to the left ventricle, okay? So hopefully that makes sense for you. So let's talk about heart failure. Now, to kind of be able to define heart failure, there's the textbook has one definition, which I think leaves something out, but then looking at the ACC-AHA definition, it kind of captures that. So our textbook says that heart failure is present when the heart is unable to pump blood forward at a sufficient rate to meet the metabolic demands of the body, or is able to do so only if the cardiac filling pressures are abnormally high. Okay, that's an okay definition, but it only talks about it at a sufficient rate. It doesn't necessarily say anything about the volume, right? Because there can be a volume problem. It kind of sounds like if all you're concerned about is a rate, you just speed the heart up and then it'll fix the problem, right? But there's a volume component also to heart failure, which you can kind of see that in the ACC-AHA definition, where it's this complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or the ejection of blood. So it's either a filling problem or it's a forward flow problem, okay? So the ACC-AHA guideline, or the ACC-AHA definition of heart failure, I think encompasses a better definition that kind of identifies this complex syndrome that we're going to talk about. Heart failure is super common in the United States. 6.2 million patients in the United States have heart failure, have been diagnosed with it. Think of this as a diagnosis of age as well. And you can see the prevalence in males in their 50s is only about 8 patients in 1,000 have it. But now they're in their 80s. Now you can see, now you have the prevalence is 66 patients per 1,000 will have heart failure. So as you get older, you're at a much higher risk of having heart failure, experiencing it. And there is a disparity between race as well. African Americans are much more likely and much higher risk of having heart failure than their Caucasian counterparts. So this is a disease that seems to have a racial implications on it as well. But you can see the mortality rate is high if you have is high and you have like a 5-year prognosis if you have heart failure. But ultimately, the cost of managing heart failure in the United States each year is about $34 billion. Okay. We've talked about other conditions and the amount of money that is spent managing those conditions, but heart failure is not a small amount of money either. And the most common causes of heart failure in the United States are things that we can treat, we can manage, we can prevent. So the most common cause of heart failure is coronary arterial disease. We talked about in block 2 how we can prevent the development of coronary arterial disease, how we can prevent that heart attack from happening, which as a consequence could prevent the development of heart failure. Okay. So we can reverse this provided we manage the conditions and prevent those conditions from developing in the first place. So we talked about how heart failure is a forward flow problem, and that measurement is cardiac output. But there's so many factors involved to influence that cardiac output. It's not just this magic number that gets thrown out. Cardiac output, if you remember from our first block, is a product of stroke volume multiplied by your heart rate. Okay? So we can adjust your heart rate, increase it, it's going to increase your cardiac output, right? We could increase your stroke volume, and that will increase your cardiac output. And the three factors that kind of go into the stroke volume, or that influence the stroke volume, is your preload, or how much blood you have available to eject out of the blood to begin with. How strong is that contractility, and how much is that pressure that we have to fight against in order to get blood actually moving in that afterload. And we also talked about in block 1 how you have this pressure loop that develops, and you can see kind of what's going on from a pressure and from a volume standpoint in that left ventricle during the cardiac cycle. And then we talked about how if I just change factors like preload, how is that going to affect my stroke volume? If I change my contractility, how is that going to affect my stroke volume? And how, if I increase or change my afterload, how that's going to affect my stroke volume. And in all of these, you'll see afterload has a negative effect on the stroke volume. So the higher your afterload, your stroke volume is going to decrease. Whereas the other two factors, contractility and preload, they have this positive effect on your stroke volume, which then will ultimately have a positive impact on your cardiac output. Okay. Now this is a chart that shows, or a graph that shows, as the preload increases, what happens to your stroke volume in 3 different states. If you have a depressed contractility state, so somebody who has left ventricular dysfunction, you can't squeeze or have a powerful squeeze, what that's going to look like, what a normal heart looks like, and then let's say somebody who is physically active and has a much stronger heart and is able to pump blood more effectively, how that's going to influence ultimately your stroke volume. And you can see, okay, you've got a nice little curve here, that's great, you can definitely see that in the increased state, but looking at the line on the decreased contractility, yeah, there is some upward motion, but it's almost like a straight line, right? And then it kind of plateaus and becomes a problem, right? Well, let's superimpose that when you get a preload that's too high, it can cause pulmonary congestion. So preloads at this level causes pulmonary congestion. But if I reduce my stroke volume, there's a point where it's not going to provide an adequate blood pressure, and now I have hypotension. So you become symptomatic, okay? So if I superimpose these boxes over that area where there's symptoms that develop, you can see now in that diseased heart, look at how little room you have before you become symptomatic. So any deviation of that function will then, or the parameters that affect cardiac output, any deviation could easily swing somebody over to decompensated heart failure. And now they're symptomatic related to that heart failure, okay? The other two states, like a normal versus an increased contractility, you can see we have a lot more room to tolerate variations in those parameters. But in the diseased heart, very little deviations can lead to symptoms, okay? When we talk about heart failure, there's a lot of definitions that kind of get thrown out there. So we're going to go through each one of these so we can kind of talk intelligently about heart failure and be able to communicate what we are trying to say and have that understanding. And these are not mutually exclusive. So these are terms that you can apply and mix with each other to kind of give you a much better description of the heart failure that the patient is experiencing. Because that could alter your treatment depending on which one or what's the definition or the classification of the heart failure actually is. Okay. The first thing that we got to establish is, well, what is a normal ejection fraction? Normal is anywhere from 50 to 70%. Okay, so your heart is not at 100% ejection fraction. Okay, 50 to 70% is a normal ejection fraction. And that's important because as we start looking at the different classifications of heart failure, that may play a role. So the different classifications, ultimately what we're looking at is when we talk about a systolic dysfunction or heart failure with reduced ejection fraction or HFrEF, what ultimately is happening is there's a forward flow problem, so I can't squeeze that blood out properly or at an adequate volume in order to maintain a cardiac output or an appropriate cardiac output. So ultimately it's a cardiac output problem, but the problem is a volume where I can't get that pressure or I can't get that out of the left ventricle. Now compare that to heart failure with preserved ejection fraction or HFpEF, where ultimately the pathophysiology in this is a decreased cardiac output similar to the HFrEF, but the cause of that decreased cardiac output is different. And it's because I have a filling problem. So I just cannot take on a reasonable volume, aka preload, to the left ventricle in order to support an appropriate cardiac output. So you can see HFrEF is an emptying problem, HFpEF is a filling problem. Okay. When I talk about left-sided heart failure, what I'm talking about is they're going to display symptoms of the lungs, like pulmonary congestion and everything like that. The lungs are going to be impacted by that left side failing. When I talk about right-sided heart failure, now I'm getting that peripheral congestion. So I'm getting that JVD, I'm getting that peripheral edema, I'm getting that gut edema. So that is a right-sided failure or symptoms of a right-sided heart failure. When I get a low output, this is what we typically think of. Kind of think of it as that cardiac output is too low to meet the demands. And then there's this high output, which is when you have a state where the heart's having to function at a much higher level than normal, like you have a fever or something like that. You function at a much higher level that eventually the heart cannot keep up and it wears out. Okay? So that is what a high output heart failure is. It's just basically the heart wears out because it can't keep up with that elevated pace to circulate the blood volume appropriately. Now when we go back to talking about systolic dysfunction or HFrEF, this is the most common cause of heart failure you're going to see in your patients, okay? So 2/3 of patients have this, and typically we think of this as being a coronary arterial disease problem, okay? There are some other things that can cause it, like having an increased afterload, like you have somebody with poorly controlled hypertension, chronically poorly controlled. Could be from aortic stenosis, we talked about in the review question. Aortic stenosis causes a ventricular pressure problem, and that can lead to this HFrEF from developing because has to work too hard to overcome that pressure. But ultimately, the pathophysiologic change that a patient with HFrEF experiences is decreased cardiac output. And it's because you end up having this elevated end systolic pressure, this elevated end systolic volume, which then means that because I have this higher volume, higher pressure in the left ventricle at the end of systole, when diastole starts, and I'm supposed to have that flow of blood coming from the atria and into the ventricle, not much can flow because I already have that higher volume, higher pressure there. So that backs up, that pressure and that volume backs up into the atria, which then will communicate and back up into the pulmonary circulation, causing pulmonary congestion and everything like that. Think of the I Love Lucy clip with those chocolates coming faster and faster and faster, and just can't keep up. Okay. HFpEF, heart failure with preserved ejection fraction, is less common than HFrEF, but it still represents about a third of our patients. And you may have a question, if the heart is failing, but my ejection fraction is preserved, how is it that I have this scenario or this situation happening? And it really comes down to math, okay? So unfortunately, I'm going to walk you through some math. I don't expect you to calculate this on your test, but I'm going to do this to illustrate, help you understand why HFpEF has a normal ejection fraction, but you still have a failed heart, okay? So going back to our math, ejection fraction is calculated by taking the product of your end diastolic volume, subtract your end systolic volume, take that number and divide by your end diastolic volume, and then multiply by 100 to get your percentage, right? So let's say that my end diastolic volume is 4, and let's say my end systolic volume is 1. So that equals, sorry, I'm trying to do this on this. So that equals 3, right? So 3 divided by 4, my end diastolic volume, is equal to 75%. So that looks like a good ejection fraction, right? Sorry, gosh, this is hard. So 75% is my ejection fraction. That's a little high, but you kind of think of that as that's a normal ejection fraction. But when I think of my cardiac output is my stroke volume times heart rate, right? So my stroke volume in this exact scenario is 3, and then let's just say heart rate's 60. 3 times 60 equals 180. So I'm only moving 180 milliliters per minute in this state, okay? Now, let's do now the math of a normal heart and compare the difference. So let's say that our end diastolic volume is 10, and let's say our end systolic volume, because I'm able to squeeze the majority of the stuff, blood out, is 1. That means then the product of that 10 minus 1 is 9, right? 9 divided by 10 is 90%, okay, still normal. But let's now calculate what my cardiac output was. So 9 was my stroke volume, times 60 is 540 milliliters per minute. So you can kind of see now, even though the ejection fraction in HFpEF is normal, the cardiac output is actually significantly reduced, 540 compared to 180. Okay, imagine that difference in volume and the demand difference that can be met with a normal heart versus a heart affected with HFpEF. Okay. Does that make sense why HFpEF has a normal EF but still is a failed diseased heart? Okay, all right. Things that can cause this is poorly controlled chronic hypertension, where you start to get that left ventricular hypertrophy. We'll talk about hypertrophic cardiomyopathy and restrictive cardiomyopathy on Friday. But there's all these other things that ultimately cause a stiffening or a decreased compliance of the left ventricle that leads to HFpEF. Okay. And ultimately what happens with HFpEF is because I can't fill that ventricle appropriately, volume, just with a little bit of volume, is going to rapidly increase the pressure in the left ventricle. That pressure and then that extra residual volume is going to back up into the left atria, which then backs up into the pulmonary system and causes pulmonary congestion. And a lot of the symptoms that you see with HFpEF is pulmonary, cough, dyspnea on exertion, shortness of breath. Because you also get that dilation and stretch of the atria, it can then also lead to arrhythmias developing as well. Let's move on now and talk about left-sided. This is that, we usually think of this as like the cardiac output problem because this left ventricle has a direct correlation with cardiac output. And the most common cause of this is coronary arterial disease, okay? So the most common cause of left-sided heart failure is coronary arterial disease. Compare that to the right side, where the most common cause of right-sided heart failure is actually from the left failing, and it backs up to the lungs, and then backs it down to the right ventricle. So you can see how that left side failing, how it can affect then the function of the right side, because all that extra volume, all that extra pressure is going to back up onto the right side, unfortunately. But some other causes of right-sided heart failure that doesn't involve the left ventricle would be things like pulmonary hypertension, where the right ventricle is having to strain, work harder to get blood circulating into the pulmonary system to become oxygenated. And then there's lots of other like pulmonary diseases, COPD, asthma, those kinds of things that can then lead to the right side failing. And when we talk about other things that can cause this, it could be like pulmonary regurgitation or cuspid regurgitation, where now you're having extra volumes. That's becoming a problem. And then you can even have inferior wall MIs, right ventricular MIs, that affect the function of the right ventricle. Low output heart failure is basically what it sounds like. The reduced cardiac output leads to that. And then high output failure is that wearing out that occurs in states that are heightened. If somebody has an infection and has a fever, that causes you to have an elevated heart rate, and that can lead to the failing heart. Other states of like sympathetic overdrive, where now you're just tapping away because of the sympathetic nervous stimulation, can then lead to the wearing out of the heart and lead to it failing. But this is a chronic problem, which means the heart has the opportunity to compensate, to try to change or alter the parameters in order to fix the disease. But the problem that we see with a lot of body compensatory changes is it may fix the one variable, that's the problem, or it may address that one variable, that's the problem. But unfortunately, it distorts the other variables and actually makes the condition worse. And we'll see this, we'll run through all the different types of compensatory changes that the heart will experience with heart failure. But you can see it starts to have other negative effects when things start to change, okay? So there's a couple of ways that the heart actually will compensate. There's the acute changes, so things that can the variables that can be altered beat to beat. And then there's the chronic changes, which chronic changes are really what we're concerned about, but even the acute changes or the acute steps can alter the physiology and can have a negative effect as well. We talked about Frank Starling, where as preload increases, the strength of your contraction is going to increase, but it's going to do that up until a point where then, if that preload continues to increase, we then start to see that contractility start to drop, and you start to see that downslope developing on the curve. So that is Frank Starling, where increasing preload increases contractility to a point, and then you start to see that slope develop. We talked about sympathetic nervous system stimulation, where the sympathetic nervous system is going to have an effect on the heart rate. It's going to increase the rate, but it can also increase the strength of contraction, so that it increases the contractility to try to overcome that excessive preload that is present that causes the stimulation of this system. But unfortunately, there is the neurohormonal compensatory changes that develop as well. And these, unfortunately, have a lot of negative effects that can lead to long-term problems as well. So these are stimulated typically by your baroreceptors that are kind of scattered throughout the body, like your carotid arteries and those kind of things, that when it detects a parameter is out of sync, of normal, it's going to then trigger the brain or trigger the endocrine system to react to try to correct it, okay? And we can see that by it stimulates the sympathetic nervous system, but it can also stimulate the RAS, the renin-angiotensin-aldosterone system, so that now I have a preload problem to begin with, but it stimulates the RAS, so now I'm increasing my reabsorption of water and sodium, which is then only going to add to the preload problem. So how is that really going to fix the failing heart if I'm just making that preload over volume worse? And then also the antidiuretic hormone produced by the pituitary gland will get secreted, and then that will have a negative impact on volume by increasing the preload in an already over volume state. So you can see these have good intentions, but they actually make the condition worse. Okay. There's also a thing called endothelin-1, which is derived from the endothelial cells on the inner surface of the blood vessels themselves, where it will detect that maybe the pressures coming to that region are not adequate. Let me produce this endothelin-1 and release it in order to cause like a localized constriction that then makes afterload worse, or makes afterload higher, which is then going to lead to worsening of heart failure, because now I'm having to work harder to overcome that systemic vascular resistance, i.e. afterload, in order to get blood circulating. And it basically leads to this spiral of death. I have decreased ventricular contractility, which reduces my cardiac output. I activate my neurohormonal axis to try to develop these compensatory changes. That increases my vascular resistance, which then increases my outflow resistance, which is just going to then lead to my ventricle is not going to be able to function as well. And then you can just see how this just continues to spiral out of control. All because good intentions don't actually take care of the real problem. Fortunately, we do have a system that actually does understand what is going on, and it reacts to the stretch of the ventricle or the stretch of the atria, and that's your natriuretic peptides, okay? There's a couple of different flavors of natriuretic peptides. There's the atrial natriuretic peptide, which is released when the atria stretches. There's the ventricular natriuretic peptide, proBNP, those types of things. And those react to the ventricular stretch or stress. But ultimately, what happens when these get secreted is it's going to cause an excretion of sodium in water. So I'm getting rid of excess volume. I'm going to vasodilate, which is going to reduce my afterload so that my heart can function better. I'm going to inhibit renin secretion. So I'm going to block the RAS activation, so I'm not reabsorbing water, reabsorbing sodium, and increasing my volume in an already overload state. And then it also blocks angiotensin 2, aldosterone, so again, more components of the RAS system being blocked. And then ultimately another effect is it actually antagonizes the effects of vasopressin, so antidiuretic hormone. So now I'm addressing that volume overload state at multiple levels to try to prevent those negative compensatory changes from happening. So the natriuretic peptides are the only thing that actually knows what's going on and actually targets the problem itself to make the scenario, make the situation better. Okay. Now, let's talk about chronic things that can develop. So you have a patient who's had heart failure for an extended period of time. Some compensatory changes that may develop is, well, if I'm not strong with my squeeze, let me make my muscles bigger. Okay? So you get this hypertrophy, and this is called concentric hypertrophy. In a couple of slides, I'll show you exactly how this makes it stronger. But this is, it typically develops in the setting of excess pressure. So this is a pressure overload problem. This develops so that you can generate a higher or stronger squeeze to overcome that pressure problem and get blood circulating. But the problem with this is, the stronger I am, the more hypertrophied my muscle is, the less flexible, the less elasticity you're going to have. Imagine this bodybuilder trying to bend over and touch his toes. Probably not going to happen, right? Ask him to reach behind him. He's probably not going to be able to do much because his flexibility is going to be reduced because of all that hypertrophied muscle, right? Same goes with the heart. When I hypertrophy the left ventricle, now I'm not going to be able to stretch out and be compliant in order to take on volume. But I can generate a powerful squeeze. Okay, so you kind of play off the two. Now compare this to eccentric hypertrophy, which is a thing where we're trying to, or this condition develops where there's an excess volume problem. And what happens is, because of that excess volume, the heart is having to work harder to maintain contact with the myocyte adjacent to it. And so what it does is it just says, okay, instead of me maintaining this excess stress, let me just add on more cells. And now, or sarcomeres, now I am longer, but the problem is, think of it as a rubber band that's been stretched too far. I now lose my elasticity, and now you get a reduced cardiac output because you can't generate a powerful squeeze when this happens. So ultimately, concentric hypertrophy develops in pressure overload states. Eccentric hypertrophy develops in volume overload states. And the way that this happens is, so this is what a normal cardiac myocyte looks like, okay? When I have a state where I'm having a higher pressure, to make myself stronger, what I do is I lay down extra sarcomeres in parallel to each other, and just makes that muscle cell, that myocyte, bigger, okay? But unfortunately, that means then the lumen of the ventricle starts to shrink, because I've got to put that enlarged muscle cells somewhere, right? Eccentric hypertrophy, instead of trying to make it stronger, remember I have that stretch problem that I'm trying to overcome. What happens is those sarcomeres get laid down in series, so they're kind of adjacent to each other, so it makes the rope longer, but now I lose that contractility because now I have a less rebound to contract, because I'm just making that cell longer, okay? So these are some of the chronic changes that can develop in a diseased heart state. And yes, it's trying to address the problem, but it leads to other outcomes that have negative consequences, okay? And this is what you're going to see. So look at the pressure loops here. So in HFrEF, where I'm going to have that eccentric hypertrophy, I can accommodate a higher preload, so you can see my pressure loop kind of gets shifted over to the right here. I'm tolerating higher pressures, or higher volumes, but the problem is I can't generate a better squeeze, so I lose stroke volumes, because I can't get up here, and I'm not squeezing all of this volume out, okay? So you can see in an eccentric hypertrophy, it pushes the pressure loop down and to the right. Concentric hypertrophy, on the other hand, where now I'm less compliant, I can't take on more volume, but I can generate a much more powerful squeeze. You can see it's going to shift the curve up and to the left, and what you see is, one, my pressure rapidly increases with volume changes. I can generate a more powerful squeeze than normal, but I'm missing out on all of this work, or this stroke volume here, illustrated by the dotted normal pressure loop. So you can see how this negatively impacts the pathophysiology of the heart. Another thing you may hear is a term called acute decompensated heart failure. Basically, heart failure is a chronic problem, maybe some minor symptoms, but then when the condition acutely deteriorates and that cardiac output is acutely affected, then it leads into this decompensated heart failure condition. And you can see the acronym HEART failed can help you remember some of the potential causes of this acute decompensation. One of these things is dietary indiscretion. This could be like Thanksgiving dinner or Christmas or New Year's or whatever, where somebody normally eats a low sodium diet, or they don't consume any alcohol, and then there is a celebration of some sort, and they start eating high sodium foods, they drink more alcohol, and that can precipitate an acute decompensated state. So when you're working on inpatient medicine, expect, if you're working around Thanksgiving, Christmas, New Year's, expect to see a couple of days after a bunch of people coming in with acute decompensated heart failure, because they didn't stick with their diet that they are required to be on to manage this condition from a day-to-day state. So, but it is so common to see these patients come in. And when they come in, this is the level of care that they're going to need, because they have all this extra fluid. Kind of think of it as going back to the I Love Lucy analogy. They couldn't keep up with the chocolates on the conveyor belt, so what did they start doing? They started putting it in their hats, they started putting it down their shirt, they started eating them. They're packing it away somewhere that could take it, right? And that's what happens in the heart failure state, is all this volume starts to back up. So you start packing that volume in places that will take it, i.e. the lungs, i.e. your lower extremities, in the soft tissue, the abdomen. All of these areas are going to take on that extra fluid, that transudation of fluid out of the blood vessels to try to help correct the overload state. Okay? They say water is about 8 pounds per gallon, right? It is not unusual for patients when they come in this state that they are 30 pounds heavier than normal. So it tells you how much excess water they potentially have in all these spaces that you have to get out to try to restore the normal functions of those organs, okay? And so the symptoms you're going to see, if this is a left-sided problem, are the pulmonary symptoms like pulmonary congestion, crackles, rails, shortness of breath. I can't bend over without feeling short of breath, or I can't lay flat in my bed. I have to have a couple of pillows underneath me to keep me upright to be able to sleep, to breathe, because what's happening is that gravity is bringing that fluid down into the bases of the lungs instead of staying up in the apices of the lungs. If it's the right-sided, which again, remember the most common cause of right-sided heart failure is left-sided heart failure, you're going to see that peripheral edema, you're going to see that JVD, you're going to see that gut edema, which also kind of, when the gut gets edematous like that, you start to lose your appetite. So you start getting anorexia with it. So a lot of symptoms that kind of go into pointing to if this is a left-sided heart failure or a right-sided heart failure. So if you see just isolated JVD or isolated peripheral edema, then you know that it's just the right side that's failing. But if you see those symptoms along with pulmonary congestion or pulmonary symptoms, then you know that it's the left side that's failing that's causing the right side to fail as well. So does that make sense? And these are just some other findings. We talked about the anorexia, we talked about the weight gain. We stopped perfusing the kidneys properly. So you think we have this fluid overload state, you pee out more, right? Well, if I'm not perfusing the kidneys, how are the kidneys going to filter out and urinate more and get rid of that extra volume? So you start to see urine output starts to drop because you're not getting that blood to the kidneys themselves. Just some physical exam findings that you can have, or you can find to help you with the diagnosis of acute decompensated heart failure. This is just an FYI slide because nobody really uses it, but if you look in literature, they talk about Framingham criteria to help you with the diagnosis of heart failure. You would think that this would be similar to like the Jones criteria or the modified Dukes criteria to help you with diagnosis, but unfortunately, it's not really all that great because look at what one of the major criteria is. They've lost at least 4.5 kilograms in 5 days in response to treatment for presumed heart failure. So I gotta presume it's heart failure, I gotta treat them with diuretics because I think it's heart failure. Let's see if they lose at least 4.5 kilograms because of the medications. If they did, okay, yes, it's heart failure. But it's 5 days later. So how useful is that in a diagnostic criteria? Because if you're like on the fence, is this heart failure or not, I gotta wait 5 days to see if it is. It's not really helpful. So that's one of the reasons Framingham criteria is not very helpful in the diagnosis and management of your heart failure patients. Let's go ahead and take 10 minutes, and then we'll come back and finish this lecture.
Which one is it? What's the sign? Got the 4 hours the other day, and No, I'm just my wife like that. I'm gonna have to learn my computer. So the thing is, like, yeah,
Yes. So it's going to well, somebody All right, let's get back to our lecture. Okay. When you go to work up a patient with suspected heart failure, you're going to want to do a workup that consists of basically all of your ancillary studies. So you're going to want to get laboratory things. You're going to want to get a chest x-ray if you're looking for evidence of that pulmonary congestion, right? You're going to want to get an EKG to make sure there isn't arrhythmias present or a heart attack, because remember when we go back to our heart failed acronym for things that cause acute decompensation, arrhythmias and MI are potential causes of the failed acute heart. Okay. And then echocardiogram is going to be important because the echo is going to give you an idea of what type of heart failure exacerbation you're dealing with. Is this a HFrEF that got worse? Is this a HFpEF that got worse? Because you're going to change and kind of alter potentially how you manage those patients depending on what's going on. The laboratory tests that you're going to get, okay, some routine ones, CBC, CMP, because you want to see in addition to how the kidneys are functioning, but you also want to see how the liver is functioning too. If I'm not perfusing the kidneys, I may not be perfusing the liver properly, so I'm not getting that toxin filtration that the liver does. You're going to look for the other potential causes of this acute decompensation. So looking at iron studies, thyroid. You're going to definitely want to get your BNP or pro-BNP depending on your facility and what they offer to help, because it's going to help you determine, one, is this heart failure that's causing this acute decompensation? And two, how bad is the heart failure? Because the more severe the failure, the higher those values are going to be. And then those tend to respond and go down as you treat the condition itself. Pro-BNP or BNP, the natriuretic peptide tests, those are the best tests that you can order and conduct in order to help you differentiate cardiac causes of shortness of breath and other causes. So, like for instance, you have a patient with a history of COPD coming in with shortness of breath. Is it because he has heart failure, or is it because of the COPD exacerbation kind of thing? The BNP, or the natriuretic peptide test, will help you differentiate that from pulmonary causes. And normally when we talk about BNP, typically any values over 400 tend to be considered positive for heart failure. Typically those values are less than 100, so you do get some wiggle room before you kind of meet the cutoff for this is somebody with heart failure. Now the pro-BNP, which is probably more commonly used in our military treatment facilities, there's an age dependence as far as what meets the threshold or the cutoff to say somebody has heart failure, okay? And this may look difficult, but just think of it as if the patient's less than 50, anything greater than 450 is considered positive, okay? Let me add 25 years to this value, and now let me just double the normal value. So anything greater than 900. Now let me just go anybody greater than 75. Now 1800 is kind of the threshold. So you just kind of double the values by changing the age range. Less than 50, 50 to 75, greater than 75. Okay. Chest x-ray, you're basically going to see the signs of that pulmonary congestion if this is a left-sided heart failure picture, right? So you're going to see those curly B lines and all those other findings that you talked about last semester. Here's just some examples of that. Here's some curly A's, curly B's, those types of things. EKG may be normal, but you're kind of doing that to just make sure there aren't other causes of the heart failure going on that need to get treated, i.e. again, arrhythmias, or there's evidence of a heart attack or something like that. But your echo is going to be your test of choice because you're going to be able to assess what that EF is. And again, you're going to be able to assess what are the secondary impacts of that EF derangement, okay? Now the last thing, once you kind of get that stuff done, now you're going to be able to classify the heart failure, okay? And I hate memorizing things for the sake of memorization, but unfortunately this slide and next slide is one of those things that you're just going to have to memorize because on standardized tests, they are going to describe a patient according to these two classifications, and then you have to assess then what classification of heart failure they meet and what's the treatment, okay? So that's why you have to kind of memorize this. But the two classification systems that you'll see, and oftentimes they are kind of applied, is the New York Heart Association, or NYHA classification, and the ACC, American College of Cardiology, American Heart Association staging classification, okay? And what's interesting is the NYHA, it looks at function, okay? So when we go to do the different classifications, Class 1, no limitation of physical activity. So think of that as no limitations of function. Class 2 is there's a slight limitation of function. Particularly they're comfortable at rest, but ordinary physical activity results in symptoms. Okay. Class 3, there's marked limitation, meaning that they're comfortable at rest, but now less than ordinary activity causes them to have symptoms. And then class 4 is they are unable to carry out any physical activity. So basically think of these folks as stuck in the bed, in their beds, or on the couch. Because any kind of motion, movement, exertion causes symptoms. Okay. Now the ACC-AHA guidelines, or staging criteria, they are much easier kind of to understand because also they are directly affect how we treat and manage the heart failure in that goal-directed medical therapy algorithm that I know you talked about in PhRMM. And we'll talk about it in our next lecture here in 2 minutes. But what's interesting is there's a specific definition to the staging that allows you to determine what is the appropriate algorithm to follow in management of these patients. So stage A is that there's a presence of risk factors for heart disease. So there's no evidence of disease, there's just that patient has a risk factor for it. So somebody who has diabetes, and all they have is diabetes, they're stage A, because they're at risk of developing. Somebody with hypertension, even if it's well controlled, they now have a medical condition that can make them susceptible to developing heart failure, so they are considered stage A. Stage B is they have now evidence of heart disease, but there are no symptoms whatsoever, okay? Stage C is heart disease is present and they have symptoms. And then stage D is it's advanced, and despite being on goal-directed medical therapy, they are still having symptoms, okay? So kind of keeping that in mind as far as the classifications go, it'll make sense as we talk about the management, why we escalate care and the requirements for the goal-directed medical therapy as that staging gets worse. But if you wanted to know how does NYHA and ACC-AHA classifications kind of correlate with each other, you can see, so stage A, ACC-AHA stage A, is in a classification by itself. It doesn't meet a NYHA class yet, okay? Once they get to stage B, now they are class 1 NYHA. Class 2 once they get to stage C, now you're looking at, they could be class 2 or class 3, so they can have either mild limitations or moderate limitations as a stage C. And then as they get to stage D, they can be class 3, but they're kind of teetering on the edge of being class 4 according to the NYHA, so having severe impacts to functional, or severe impacts to function. So that's how your ACC, AHA staging and your NYHA classifications kind of tie into each other, okay? All right, that's the end of this first lecture. Let me just switch over. If you're good, I'm going to push till 2:50 before we take a break. Does that sound good? Okay. Get this one pulled up. Okay. So we're just doing a couple of check-on learnings from that last lecture that we just listened, but we're just going to quickly roll through it. So which of the following is a potent vasoconstrictor derived from endothelial cells lining the vasculature? Correct. Yep, endothelins in the name. So,
Question 1.
which of the following is the most common cause of heart failure? Yeah, I heard CADS, coronary arterial disease, so number B, or letter B, is the correct answer. So yes. Okay, good. Glad to see we retained that information that I talked 2 minutes ago. So. All right. But today, this lecture is going to focus on how do we treat heart failure, okay? And remember, we talked about how you're going to need that echo in order to differentiate which type of heart failure you're dealing with. If you have a heart or EF of less than or equal to 40, then this is HFrEF. So we said a normal EF is 50 to 70, right? So I have an EF less than 40, less than or equal to 40. Now I need that HFrEF. So I've got a delta of 10, where now you're in like this mildly reduced ejection fraction. Kind of think of this as your borderline heart failure. If the EF is greater than or equal to 50, so it's in the normal range, then that is preserved, heart failure with preserved ejection fraction. You hear people talk about HFrEF, HFpEF, it almost sounds like a dog barking at you, right? But there are specific meanings when you use or you correlate or you classify these patients as heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And you can see the workup for this is not a slide for you to remember, please don't spend the time to do this, but there is lots of testing that goes on to the diagnosis of these patients with heart failure, okay? And we talked about the classifications, ACC-AHA staging, and then we talked about the NYHA functional classification and how those two things correlate with each other. And when you go to take care of a patient with heart failure, you've got to assess, well, what is the underlying cause of their diseased heart state, okay? And there's lots of things there that can cause heart failure to develop. So once you have identified, do they have poorly controlled diabetes? Okay, let's start treating that diabetes. Is it poorly controlled hypertension? Let's start treating that hypertension. Let's treat the underlying problem instead of just treating the disease, right? Because you can, hopefully you're catching them when they're just stage A and they stay stage A. But let's say you catch them when they're stage B, where they're not having any symptoms, but they have that structural functional problem present. How do I prevent them from progressing to stage C, where now they're having symptoms from their diseased state, okay? And this is, it's important to identify those causes so you can prevent the progression of their disease. But let's look at how we manage HFrEF. Remember, HFrEF is for patients with EFs less than or equal to 40%. Okay, let's talk about treatment. So one, okay, identify the underlying cause and correct it. Let's eliminate any of the acute precipitating causes, so arrhythmias, infections, those types of things. Let's manage the heart failure symptoms, so that fluid overload state. Let's start to treat those with things like diuretics, vasodilators, and ionotropes, depending on what's going on. Let's modulate the neurohormonal response. So all of those negative neurohormonal kind of things that get activated to try to fix the diseased heart, let's block those because those have negative effects on the heart, despite their good intentions. And then, of course, the last thing is let's prolong life, but let's also prolong quality of life, okay? Let's keep their functional state going. And let's look at how we do it with stage A, heart failure first, okay? Remember we said stage A is that there's just a risk factor. They have risk factors for heart failure. There's no symptoms, there's no structural, there's no functional changes that have occurred. They just have a condition that makes them at risk. And this could be conditions like hypertension, coronary vascular disease, diabetes, obesity, exposure to cardiotoxic agents. So this would be like your cancer patients who have had chemotherapy or radiation. They're at risk of heart failure based on those cardiotoxic exposures. So those are a few of the things that would put somebody in a stage A heart failure. So when it comes to stage A, we treat it, there's an algorithm for it, and it says, okay, if they have hypertension, optimal control of blood pressure. You see, it does not say a specific medication. So it doesn't say it has to be an ACE inhibitor. It doesn't say that it has to be an ARB. It just says manage their blood pressure. So go back to our primary agents for hypertension, you could pick any one of those. And you meet, as long as you get that blood pressure to goal, you can meet the criteria of addressing and meeting this goal in treatment, okay? if a patient has type 2 diabetes and coronary vascular disease, or they're at high risk for it, then they should be on an SGLT2. And I would add a slash there because evidence and new studies have shown that GLP-1s also kind of fit in. So anytime you see SGLT2 in the treatment of heart failure, just automatically put a slash and put GLP-1. I imagine when the guidelines are updated, GLP-1s will show up. It's just all this new evidence of GLP-1s is finally coming online, and the studies have shown positive cardiac benefit with GLP-1s, similar to SGLT2s. And if you want to give them even more bang for their buck, you can put them on both a GLP-1 and an SGLT2, provided their sugars tolerate it, right? If patients have coronary vascular disease, let's treat it. So they have coronary vascular disease, let's go ahead and put them on a statin. Let's reduce that coronary vascular disease burden that they have. Or maybe they need a stent, depending on how bad it is. And then there's some other things. Okay, if they have a first-degree relative with a genetic or inherited cardiomyopathy, then let's do genetic screening, counseling, and those kinds of things. So you can see stage A is basically just manage the condition to prevent progression. Okay, and kind of as a side note, for the test, I will give you each one of these ACCAJ treatment algorithms for reference. Okay, so you don't have to memorize how to treat stage A. You don't have to memorize treat stage B, C, D, or HFpEF. I will give you those algorithms for reference, similar to what I did with the lipid algorithm. Okay, so you'll have those for reference on the test. So don't spend your time memorizing these things. There's so much other information that I would like for you to spend your time memorizing for the test. Just be familiar on how to use these algorithms. Our lab for block 3 is just one section, and it's really just focusing on using these algorithms and applying clinical scenarios to these algorithms, okay? So we'll get more experience with these as time goes on. Okay, so we talked about stage A, or at risk for developing heart failure. Now let's talk about stage B. And to be stage B, you have to have the structural or functional effects or change, but they have no symptoms. Okay, so they have a change without symptoms with it. And the things that can qualify somebody of having structural or functional changes is like reduced left or right ventricular systolic function, so like their EF has dropped. They have ventricular hypertrophy. The chambers are enlarged. So you can see that these are chronic changes that can occur, and that is a stage B change. Now, functional problems, they have elevated filling pressures as evidenced by invasive or non-invasive testing, okay? So you have that pressure increasing there. And so what we do now is, now you're going to start to see in the algorithms and the treatment management that there are specific medications dictated to add and manage these patients with. So patients who are stage B, who have that EF of less than 40%, they should be on an ACE inhibitor. It's green, meaning it's well-proven, shown benefit. Okay. If they can't tolerate an ACE, then put them on an ARB. Okay. Patients with LVF of less than 40, they should be on a beta blocker. Okay. And then patients with EFs less than 30 have a 1-year survival, or at least a 1-year survival rate, or 40 days and 40 days post-MI. They should then get put on an ICD, so an implantable cardiac defibrillator. And the reason these patients who have an EF less than 30, who are still stage B, require that implantable cardiac defibrillator is these patients are at a much, much higher risk of developing fatal arrhythmias. So you want that ICD in place to shock their rhythm back into a normal-ish rhythm as soon as that rhythm develops instead of hours later, okay? So that's why those patients with an EF less than or equal to 30%, but are stage B, get an ICD. So we've talked about the mechanisms of ACEs and ARBs, and I'm not going to revisit that. But what I am going to talk about is the benefit with putting patients with heart failure on these medications, okay? So yes, it reduces afterload because it manages the blood pressure. That sounds great. But ultimately, ACE inhibitors and ARBs increase survival. They reduce hospitalizations by ultimately reducing the remodeling that occurs after a heart attack. So basically, those concentric changes, those eccentric changes that can develop as part of that compensatory mechanism, that adverse cardiac remodeling, these medications, ACEs and ARBs, will interfere with the development of those conditions. So that's how it leads to a mortality benefit, because it reduces those negative compensatory changes from developing. Same goes with the beta blockers, okay? Again, it has a mortality benefit for patients. The key kind of distinction is you cannot give beta blockers to patients who are acutely volume overloaded. So if they're in the acute decompensated heart failure phase, then you do not put them on beta blockers because you're just going to reduce that contractility, which is just going to make that heart failure worse, okay? But once that volume overload state is addressed, then they should be put on a beta blocker. So that's really the treatment for stage B. Let's move on. We're going to talk about stage C and D kind of together because they're on the same algorithm. But stage C is you have those structural functional things that you had at stage B, but they have symptoms. And this is the kind of thing that if they have ever had heart failure symptoms, they are stage C. Just because you treat them and now they no longer have symptoms does not mean that this stage C person can now become a stage B because they're asymptomatic, right? They will always be, at a minimum, stage C once they have developed symptoms. Because what you don't want to do is you don't want to start this goal-directed medical therapy for stage C, they get better, symptoms are treated, let me start pulling off my medications that are keeping me controlled, right? So that's the implications, and that's why you don't change the staging down. You've got to keep it to where they are at, or at the highest level for their condition. And then stage D is you basically are doing everything you can according to the goal-directed medical therapy, but they still have symptoms, okay? So that's what stage D is going to be. And when we look at the algorithm, we'll walk through these things, but you can see as we progress from the left side to the right side, we're escalating our treatments to the point where we're in our last-ditch efforts trying to help them. So let's start with step one. One, confirm that this is stage C, so they have to have that EF of less than or equal to 40 because they got to meet the definition of HFrEF, okay? So they got to have that, and they have to have had, either currently have or have had symptoms in the past, okay? So that's the first step, is to confirm that they in fact have stage C. When you confirm that, now you're going to start adding a lot of medications to their treatments, okay? You can see it says ARNI, ACE or ARB. Now an ARNI, angiotensin receptor neprilysin inhibitor, medication has an ARB in it, so you don't want to have them on ARB by itself and an ARNI because you're going to be doubling up on that ARB. If you have a choice between an ACE inhibitor or an ARB versus an ARNI, always choose the ARNI, okay? Because studies have shown that patients have a much better response if they're on an ARNI versus just an ACE or just an ARB, okay? So if they can tolerate the neprilysin inhibitor component of the ARNI, go ahead and put them on that, okay? They should also be on a beta blocker if they're not already on one. And remember, you're kind of titrating the goal heart rate of between 55 and 60. They should be on a mineralocorticoid receptor antagonist, so spironolactone or eplerenone are kind of the two more common ones that we use for that. These patients should be on an SGLT2 inhibitor, even if they don't have diabetes. They should be on an SGLT2. Okay, we said SGLT2, GLP-1s in stage A only if they had diabetes with coronary vascular disease or high risk for it. In stage C, these patients are going to be on an SGLT2 / GLP-1 because there is a mortality benefit associated with this medication in stage C, regardless of diabetes status. And then the last thing is diuretics as needed. Okay. So let's look at the new kind of treatments in this stage and talk about why it's indicated at this level. So the ARNI, which is a combination of sacubitril and valsartan. We talked about valsartan and the ARBs and how they work and the benefit that comes with those, the mortality benefit that comes with those. So we're not going to talk about that, but we're going to focus on the neprilysin inhibitor component of this. So neprilysin inhibitor, it inhibits neprilysin, which neprilysin breaks down those natriuretic peptides that are circulating as response to this stretch of the ventricle or the stretch of the atrium. Remember, we said that the natriuretic peptides are the only thing that actually understands what is truly going on and elicits positive benefits. It blocks the RAS system from activation, it blocks the effects of antidiuretic hormone, it blocks all of those other neurohormonal kind of activities and actually starts to correct the problem. So does it make sense that if I block neprilysin, that is breaking down those good things, I now increase the level of my natriuretic peptides so that I can continue to have that positive benefit associated with them? Okay, so that's how sacubitril works. So now I get that positive benefit from with the ARNI, I get that positive benefit of the sacubitril, and I get that positive benefit from the ARB component that has that mortality benefit and all those types of things to improve my lifespan and improve and reduce the adverse cardiac remodeling that occurs. Mineralocorticoid receptor antagonists, we know how they work. We talked about them briefly in block 2. But in the CHF component or the treatments, there's major benefit in that it inhibits the cardiac remodeling that occurs. So you can imagine, anytime I say it inhibits cardiac remodeling, equilibrate that with mortality benefit. Okay, I preserve functional myocytes that are working normally, responding normally, by preventing that scar tissue from developing, if that makes any sense. But you can see with mineralocorticoid receptor antagonists, I decrease my mortality by 30%, I decrease my hospitalizations by 35%, and I improve my function. So these patients are able to exercise, be more active with mineralocorticoid receptor antagonists. The one thing you have to be careful of is what other medication are they on that acts with this? ACEs, ARBs, right? And what it does to potassium. You now have two things that raise potassium. I gotta make sure that those potassium levels are not rising too high, that now we start eliciting arrhythmias because of those elevated potassium levels. SGLT2s, so your empagliflozin and canagliflozin are kind of your more common ones that we use. These work at the SGLT2 transporter site, but they ultimately carry a mortality benefit with them. So they are approved for reducing cardiovascular risk, i.e. MI, strokes, or even death. So there's a mortality benefit with SGLT2s and GLP-1s. So put that as a side note. And then your loop diuretics. So it said diuretics as needed. So furosemide or Lasix, if you're ever getting pinned on the wards, how long does furosemide last? It's in the name. It lasts 6 hours. Lasix. So yeah, that's a famous pin question for students. So it lasts 6 hours. But these work on the in the nephrons, in the loops of Henle, in dumping excess volume, sodium, and those types of things. These are great for helping improve symptoms. So I have a volume overload state. Let me get rid of that extra volume, right? The problem is it doesn't really truly address heart failure. So even though your symptoms may improve, there is no long-term mortality benefit with diuretic use. Okay. So it kind of seems counterintuitive. I'm treating the condition, that volume overload state, right? But I'm not seeing that mortality benefit associated with these medications, unfortunately. So this is just an adjunct to care. You've got to have them on all those other medications that we talked about in this stage to meet that goal-directed medical therapy requirement, okay? Okay, once we start them on all those medications, we titrate the dosages so that we're at threshold or at goal for heart rate, blood pressure, and those types of things. Then we're going to reassess where we are at. So that means we're going to need to get an echocardiogram to see, did we fix the problem, okay? And if the EF comes back greater than 40% on that repeated echo, great. We're just going to continue goal-directed medical therapy and monitor them closely. But if their EF is still less than or equal to 40%, then this is considered persistent heart failure. And now you got to go to step 3, which is consider 3 specific populations and see if your patient falls into one of those 3 categories. First one is, are they African American? If they are, then you should add hydronitrates to their regimen, okay? There's a positive benefit that goes along. It's really only demonstrated in African American communities of patients with heart failure that you don't see in other races. Let's look at, well, what is their EF? If it's less than or equal to 35% and they're in stage C, then let's put an ICD in place. Remember, in stage B, we said less than or equal to 30. In stage C, it's less than or equal to 35. They get an ICD because these patients are at high risk of developing fatal arrhythmias and so on. But one thing you do need to look at is if their EF is less than 35%, they're in a normal sinus rhythm, but you have a widened QRS with a left bundle branch block, then instead of just an ICD, you're putting in a cardiac resynchronization therapy defibrillators. So basically think of it as, this is a pacemaker with a defibrillator there. So I'm gonna pace, because I have this abnormal left bundle branch block that's maybe causing the heart to malfunction. Because of that block, I'm not coordinating the squeezes of the ventricle. Let me put a pacemaker in place to restore that coordination of the right and the left. And maybe that's gonna help improve their status by improving that coordination. But let's throw the defibrillator in there as well, because again, these patients are at high risk of developing fatal arrhythmias, and we want to shock their heart when those arrhythmias do develop. So let's talk about your African American community and why hydronitrates are good. The nitrate, it stimulates nitric acid signaling in the endothelium, so it causes a vasodilation. It reduces preload. And then the hydralazine is that direct vasodilator, and but in combination with nitrates, it actually enhances the effect of nitrates. So it makes the isosorbide dinitrate work better. And this is really, so it works better at reducing preload, but also reducing afterload with that hydralazine component to it too. So you're kind of fixing two of the variables that are malfunctioning, leading to the heart failure itself.
All these things that so like for African Americans, is it just African Americans, or like what about African, or like any black people? Is it just African Americans?
It's a good question. I don't know the answer exactly, because we're only really doing our studies in African Americans, because I haven't looked at literature from like African countries. The one thing I will say is a lot of these diseases that we talk about are a less prevalence in like African nations. Because now you're in this like the diet, culture kind of problem and discussion. So the diet here is very different from the diet in Africa, kind of thing. Does that make sense? But I don't have a great answer as far as is this effect the same for folks living in Africa who have heart failure versus just here in the United States?
So to say an Asian ethnicity comes, you're like, hey, you tried everything else, you can still try this for me,
You could, but the studies that looked at this, they didn't see the same positive benefit that we did in the African American communities. So, yeah. I think I saw another hand over here. Maybe not. Okay. So implantable cardioverter defibrillator. So it's just basically looks like a pacemaker, but instead of having the leads to pace the heart out, it's just a lead that's there to detect abnormal rhythms and shocks them. Okay, so that's all the leads do. They don't actually pace. If it's just a ICD and that's it. Okay. Now, cardiac resynchronization therapy, it looks the same, but now I have all these extra leads because I'm actually pacing the heart as well. In addition to having those defibrillators, that shocking lead there as well if an arrhythmia were to develop. Okay, so once we've done the assessment to see if our patient falls into one of those three categories, now we're going to revisit and see, did things improve? If they did, and now those symptoms have improved, then great, let's just continue our therapies that we're on and monitor them closely. But at this point, if they still are having symptoms and they're on max dose of all of the medications we talked about, if they fall into any one of those three special patient categories and we've done those things, and they still have an EF less than 40 and they're symptomatic, then they are now considered stage D. And you can see, once we get to stage D, we are running out of options to treat and manage these patients. So you're looking at, with stage D, let's do a mechanical circulatory support. So you're talking about these fancy things like left ventricular assist devices, artificial heart pumps, those types of things. So you can imagine these are very invasive tests, or very invasive procedures, because you're trying to have some other means to fix that failing heart to improve their symptoms. Other things you can do, well, ultimately, they probably need to get a heart transplant. The unfortunate thing is, it takes a long time to get a heart. So are they going to survive long enough to get a heart transplant with their failing heart, their advanced failing heart? And then you have the option of, well, do we start looking at palliative care, hospice care, kind of thinking of end-of-life kind of things, okay? So you're really limited in that stage D on what your options are, and maybe the most humane thing would be to let them pass naturally instead of doing these invasive things to try to prolong life. Okay. So here's a couple of examples of mechanical circulatory supports. Other things to kind of think about is, so we talked about high output heart failure, right? We talked about how infections that cause fever can trigger a high output heart failure. So does it make sense that maybe I could do things to reduce their chances of getting infections, that reduce the chances of getting a fever, that maybe I could help their heart remain functional? So things like flu vaccine or pneumococcal vaccines are important because I can reduce their risk of getting those viruses or getting those conditions that then would elicit an elevated heart rate and precipitate a high output failure. I should also monitor for thyroid disease. A lot of symptoms that go with thyroid disease are kind of overlap with heart failure symptoms. So we said with like hypothyroidism, you get peripheral edema. Well, one of the symptoms of heart failure is peripheral edema, right? So maybe that peripheral edema is actually from a thyroid dysfunction as opposed to heart failure exacerbation. And then you got to screen and treat for depression. Any patient who has a chronic medical condition is at high risk of developing depression. What do depressed patients do? Not a lot. They don't take care of themselves, right? They don't stick to their diets. I gave you the example about the holiday heart with dietary indiscretion. They don't stick to their diet. I'm sad, maybe I'm going to eat this whole bowl of ice cream kind of thing, right? They also don't take their medications, right? Well, if I have them on these medications that's managing their condition and then they stop taking their medications, their condition is going to acutely get worse, right? So make sure you're screening and monitoring for depression in these patients with chronic medical conditions, because medication compliance could lead to death. Other things, so NSAIDs are bad in heart failure, so don't give them NSAIDs, don't allow them to take NSAIDs, counsel them about not taking NSAIDs. And then diltiazem and verapamil, so your calcium channel blockers, are actually contraindicated in this condition because I reduce cardiac output, similar to what my beta blockers do, right? But what don't I have with my calcium channel blockers that I do with my beta blockers? I don't have that mortality benefit because of that adverse cardiac remodeling and everything like that. So don't give calcium channel blockers to your patients with heart failure because you reduce that cardiac output without allowing or causing a benefit to them being on that medication like we do with beta blockers. So let's go ahead and take 10 minutes, then we'll come back and we will finish up.
What? Dude, what the fuck do you do? What hand y'all doing? It's like any other thing. It's like, well, we could try this and try it and work, but it's like this is my last album from just keep putting something figure out who to try. So straight. It's pretty neat because I'm sure there's a study out there somewhere that says flat one out of an album. I guess what's the norm in it, I suppose, as long as it's like what you ever see.
But she did say she said she would die.
What the preferred medicine.
It's not sad. And it's not
I've been full.
Full Arctic.
I don't know, I feel like a lot of these things
Real one. Just
I feel like I should.
count up, just like a full like fucking one thing.
If there was a note card that had the name of the person who did it,
that's just the first one that came to mind.
no, probably a closer. Shake me down.
I really
about this video, like, that's not I just assume like,
Yes.
I mean, it is one hour. Yeah, man, you let me go. After you want to wait like
I can do mine.
do that too. Okay. That way, like, we're already, I'm already. Thank you, man. Wipe the walls.
Yeah. I bet you won't comment. Yeah, Mr. 08.
Alrighty, let us get back to it and finish this lecture up. the treatment of HFrEF. So let's start now talking about heart failure with preserved ejection fraction. Okay? And what you're going to notice is we don't really have great treatments for HFpEF, or at least studies have not shown a lot of benefits to the treatments for HFpEF. So when we look at the algorithm, you'll see kind of what we're limited to. But with HFpEF, remember, third or so of your patients with heart failure are going to be having heart failure because of HFpEF, so less common than HFrEF. But we're kind of limited in our treatments to treating the symptoms as opposed to preventing symptoms, if that makes any sense. And you can see on our algorithm, the only thing that really has been shown is diuretics as needed. So do they have evidence of fluid overload? Give them a diuretic as needed. It's the only thing that's been shown to have great evidence. And that's at the time of these guidelines coming out in 2022, I believe, is when they came out. Now, the one thing I will say is that studies are actually now showing that SGLT2s and ARNIs are actually having benefits to HFpEF as well. I think one of the reasons a lot of our treatments are not as refined in HFpEF as they are in HFrEF is simply because the majority of our patients are HFrEF, so the studies that have been conducted focused on HFrEF patients only. So now that we've kind of fixed the HFrEF side of things, now we're starting to invest in studies and those types of things looking at HFpEF. Okay, so I suspect when the guidelines are updated, we'll have a little more good treatments for HFpEF to prevent the progression of the disease, that adverse cardiac remodeling, the worsening of those filling pressures, the worsening of the filling volumes, and those types of things. So, but not a lot of great things as of these guidelines coming out to treat HFpEF. Regardless of whether or not this patient has HFpEF or HFrEF, though, we want to manage these patients and prevent hospitalizations, because if they require a hospitalization, that portends to a poor prognosis. So their mortality rate drastically goes up if they are hospitalized. The two main causes of death in heart failure is either the sudden development of an arrhythmia. So that's why when you get to a certain threshold, we're doing those ICDs, because that's one of the major causes of death. And then the condition itself gets worse, and medications are not going to be adequate enough to treat and improve the function of the heart. But regardless of which version you have of heart failure, the mortality rate is about 50% at 5 years. So half of your patients with heart failures will die within 5 years of their diagnosis. And it's much higher if their level of their heart failure required a hospitalization. Well, let's move on, and now let's talk about the acute decompensated heart failure and how we treat these patients. Okay. The first treatment really is, let's prevent them from becoming acutely decompensated. So how can we do this? Well, we got to identify when somebody is on a ledge, teetering, whether or not they're going to become acutely decompensated or not. And the way that we do that is we have the patient do daily check-ins for their status. Okay? So there's typically a green light, yellow light, red light card that we'll fill out with the patients. And we ask them to honestly assess their condition every morning when they wake up. And if they are considered green, they have no new or worsening shortness of breath, their physical activity level is normal, They have no new swelling of the feet, ankles, and legs look normal for you. Weight check is stable. What's their weight? And no chest pain. Great. If all these criteria are met, great. Continue daily weight checks. Continue your meds as directed. Let's continue doing a low sodium diet. And let's, of course, follow up with your medical provider as scheduled. Okay. So it's important with your heart failure patients that they know what their dry weight is, meaning in a state where they are not volume overloaded, what is their weight? So I need to know what my baseline weight is because I'm going to have to compare my weight checks to that baseline to see, is my condition getting worse? Because look what happens when we get to yellow. So now I'm having a dry hacking cough. I have worsening shortness of breath with activity. I have increased swelling of my legs and ankles. I have a sudden weight gain of more than 2 to 3 pounds in a 24-hour period or 5 pounds in a week. I have discomfort or swelling in my abdomen, and I'm having trouble sleeping, meaning I can't lay flat to sleep. I have to prop myself up a little bit. And you can see if they fall into this category, then contact your doctor or healthcare team, and then they will direct you what to do. And it could be that if somebody comes up in this category, all we need to do is tell them, take your diuretic. Follow back up with me in the morning. Go to the ER if symptoms get worse despite taking medications. Okay. So maybe all they have to do is just, instead of 20 milligrams of furosemide, maybe they're having to take 40 milligrams of furosemide instead. Okay. Now, red is, now I have a frequent dry hacking cough, I have shortness of breath at rest, increased discomfort or swelling in the lower extremity, sudden weight gain of more than 2 to 3 pounds in a 24-hour period or 5 pounds in a week, new or worsening dizziness, confusion, sadness, or depression, loss of appetite, increased trouble with sleeping, cannot lie flat. So you can see these are pretty significant, severe symptoms that develop because of that heart failure, okay? And the directions are, if the patient assesses themselves in this red category, they need to be calling 911 and going to the emergency room to get evaluated. Because this is probably what they're going to need. So you can see, when we talk about the treatments, you can see a lot of these things present. So you're going to need to keep them upright and put some kind of ventilatory support, whether it be CPAP or BiPAP, to help them with oxygenation if their oxygen levels are dropping. And remember, the heart failed acronym can help you recall things that could precipitate an acute decompensation. But when they are in that acute decompensated phase, then you're going to want to do PAMI. So P is position upright. Use the gravity to bring that fluid that is accumulated in like the pleural space down to the bases so that you can have more lung tissue that is able to aerate and exchange oxygen and carbon dioxide. Let's put them on oxygen if their SpO2 is less than 95%. Let's monitor their ABCs, and then intravenous access is important. And the reason IV access is part of the PAMI is in a fluid overload state, especially if it's affecting the gut, you are not going to absorb pills like you should. So you're going to have to transition from pill furosemide to IV furosemide, okay? Now there is a difference in the dosages. So basically an IV dose of furosemide to equal the dose of the PO, the pill, is half the dose. So what that means is, if I have a patient who's on 20 milligrams of PO furosemide, that is the same as saying they have 10 milligrams of IV furosemide. Okay. So if I'm needing to increase their dose of their diuretic to kind of start getting them to get off some of this extra fluid, then I may be able to just give them the same dose IV as they are getting at home PO, and that actually is increasing their dose of furosemide. So, but there is a dosage calculation you got to do when you switch from PO to IV when it comes to furosemide. But the next thing you're going to want to do when you have a patient who comes in with acute decompensation is you have to figure out which quadrant this patient is presenting in, okay? And the way you can determine which quadrant they're in is you have to ask yourself, are they dry? Are they wet or are they dry? So do they have extra fluid? Is their volume state overloaded, wet, or is it dry, not overloaded? Okay, so that's a volume state question. Then the next question you have to ask is, what's their perfusion status? Are they warm or are they cold? Are their extremities cold? Because that's going to tell you, is blood circulating to the distal parts of the body appropriately or not? And then you can then combine these answers and you can have basically 4 conditions that are present. It could be that they are dry and warm. They could be dry and cold. So volume stasis is normal, but they're not perfusing. They could be wet and warm, where now they have a volume overload, but they're perfusing appropriately. Or it could be wet and cold. So they are not, they're in a volume overload state, and they are not perfusing properly. Once you've determined which quadrant they are presenting in, the treatments then are used to directly treat the underlying problem, okay? So if they're warm and dry, maybe we just need to do a temporary increase to their home diuretic and then optimize chronic therapy, that kind of thing, and that's all we need to do, stabilize them. But if they're warm and wet, so they're perfusing but their volume overloaded, then I'm going to give them something to address that volume overload. So I'm going to give them diuretics. And then I'm also going to give them a vasodilator to reduce afterload to improve cardiac output. Okay? If they are cold and dry, so now they're not perfusing, but they are not in a volume overload state, I need to address that perfusion problem, okay? So what am I going to do? I'm going to give them ionotropes to make that squeeze better, okay? So I'm trying to raise that cardiac output, raise that blood pressure up, and then I'm typically going to give them also a vasodilator. Once their blood pressure comes up, that's the one caveat, because you don't want to give them, you know, their systolic blood pressure is like 82. You don't want to hit them with a vasodilator that's going to drop that, and hit them with an ionotrope to raise it. You're going to want that pressure to come up first before you're dropping that pressure with the vasodilator. Cold and wet is going to be the worst presentation, because not only are you volume overloaded, but you also are not perfusing properly. And you can imagine it's kind of a combination of both of those things, where they're going to be getting that diuretic to address that volume overload, but they're also going to get that ionotrope to improve the contractility of the heart. And then when pressure supports putting them on a vasodilator, you'll put on that. So how do you know if a patient is wet? So they're in that volume overload state. Could be that you notice that they have an S3 and or they have jugular venous distension, so some physical exam findings. They may have symptoms that suggest a pulmonary congestion, so like breathing problems. They might have peripheral edema, and then on your exam also you may actually appreciate those crackles that you can see with pulmonary congestion. So those are things that would suggest somebody is wet or volume overloaded. Now, if they're cold, okay, cool extremities is one, but even cyanosis, we talked about peripheral cyanosis in block 1, right? That can lead to, that would be a diagnosis of low perfusion or being cold. But other things would be that they are altered because they are not perfusing the brain properly, okay? So that would show that there's a perfusion problem there as well. So let's talk about the diuretics that we have at our disposal. The most common one that we're going to use is going to be your loop diuretics like furosemide, because these are the best at acting and lowering and better tolerated. They even work when the kidney is not really functioning as well as you would like. So, so you can even give these in patients with chronic kidney disease. The thiazide or thiazide-like diuretics, you can use some of those in combination with furosemide, but they don't work as well at getting rid of volume like the loop diuretics do. So we typically will use loop diuretics over the thiazide-like diuretics. But ultimately, regardless of which diuretic you choose to treat your patient, it may treat the symptoms, but again, there is no mortality benefit with the use of diuretics. And that's why we have to use all those other things to help with the mortality benefit. When you talk about your ionotropes, there are two main ones that we consider using is dobutamine and milrinone, okay? Dobutamine works great, but if somebody's on a beta blocker, they came in and already on a beta blocker, it may not have the same effect as it would be if they weren't on that beta blocker. So if they're on a beta blocker, then maybe consider giving milrinone instead, because you don't have that beta agonist antagonism kind of interaction between dobutamine and a beta blocker. Okay, so let's look at how do we treat these things. So we said warm and wet, so they are perfusing, but they're volume overloaded. Let's do a loop diuretic, and let's give them a vasodilator agent like nitroglycerin to help with the preload and the afterload. If they are cold and dry, so they're not perfusing but they're not volume overloaded, then give them the ionotropic agents like dobutamine or milrinone, and then once their blood pressure tolerates, go ahead and give them nitroglycerin to help again with that preload and that afterload. And then cold and wet, you're going to do those three agents. So you're going to give them diuretics to get that volume overload out. You're going to give them ionotropes to help improve that cardiac output. And then when their blood pressure will support it, go ahead and put them on a vasodilator. But there's other things that you can use as well to help you with this. One of them is you can put them on hemodialysis. The indications for hemodialysis is best exemplified by the mnemonic AEIOU. So the vowels, A is acidosis, E is electrolyte abnormalities, I is intoxication, O is overload, i.e. volume overload, and then U is uremia. So, so there is an indication for hemodialysis in these patients with a profound volume overload state. Okay. But other things that you might think about, especially if they're not responding to those ionotropes, is maybe looking at doing some of these mechanical circulatory support devices. So things like an LVAD, a left ventricular assist device, or an intra-aortic balloon pump that kind of coordinates the inflation and deflation to help propel blood through the aorta and down into the peripheral arteries, okay? But ultimately, if they are that bad, then it may be that the condition is irreversible and they just need to be put on a heart transplant and wait for a new heart to become available to address the malfunctioning heart. But to kind of finish the lecture on a somber note, things that maybe, I know it seems like that's the trend for me, but the things you need to consider, if they are getting to this point, what are the wishes of the patient, right? So you gotta start having a palliative care kind of discussion with them. And fortunately, when you're in the hospital, you typically are not the one having to have this discussion with them. You may be in the room when the discussion is happening, but there is a palliative care team that will come up and talk to the patient, talk to the family to help coordinate this palliative care, okay? Because this is a tough decision, especially if plans were not made beforehand, there's not an advanced directives and those types of things. Now the kids are having to make the decisions for their parent. It becomes rough because you don't want to feel like you're giving up on your mother or your father. And it becomes a very, and you can even get to the point where one kid might have feelings of one side and the other one has another side, and now you get a family argument that gets involved. So, but one of the things that can help you kind of gear the discussion to maybe we should be thinking palliative care, hospice care, make them comfortable with the little time that they have left is, what's their age? If they're over 70 and they're presenting this way, chances of a meaningful recovery are slim to none, okay? Do they have end-stage disease of other organs? So in addition to now this heart failing, do they have chronic kidney disease and the kidneys are not functioning properly? How are their lungs? They have a history of emphysema, COPD, and asthma, and now you have this heart failure. Probably not going to bode well for that patient. And then you can look at some of the other kind of organ systems that could be affected. But this is the time, if they're presenting this severe, that you need to start considering patients' wishes, and then ultimately open that discussion for palliative care, making them comfortable with the time that they have left. So, question?